This presentation will be part 2 of 3 for the pre-lecture material for the grade 5 mobilization for the Stanford Healthcare Orthopedic Residency 2020. In this part 2, Taylor will be taking us through the overview of the evidence of spinal manipulation. This will include manipulation versus mobilization, the effects on the CNS, pain and disability, the outcomes of range of motion, as well as motor output.
We're going to start with an overview of the evidence. And what do we do? To manipulate or to mobilize? It's a really good question. When we look at the cervical spine, we haven't found the ideal dosage for cervical manipulation, thoracic manipulation, or cervical mobilization for the treatment of neck pain. In all the evidence, we haven't had anything that has shown us what is the optimal dosing based on the controlled trials available. However, there is moderate to low quality evidence that manipulation to the cervical spine produces a similar change in pain and disability when compared to mobilization for subacute or chronic neck pain at short-term follow-ups. So that leaves the question, where do we go from here? So looking at the rest of it, there is some suggestion that at immediate or short-term pain relief can be obtained with either of the two. However, we're not truly seeing that it can be maintained over the long term as of yet. When looking at other things, Dunning, who's a pretty big advocate for spinal manipulation, found that combining approaches with manipulation of the upper cervical spine and the upper thoracic spine had greater improvements in disability, pain, range of motion, and performance than the non-thrust or mobilization techniques. But again, their follow-up was only 48 hours later. No long-term data. Continuing to look at the two different ones, we see that specific to manipulation, it might be a better option than that of TENS or massage for those who have chronic cervicogenic headaches. It can be more effective than some medications than acupuncture or soft tissue massage, just mentioned above, for those who have subacute or chronic neck pain. For mobilization, still very low to low quality evidence. However, it suggested that the AP mobilization performed with the patient in prone is slightly superior to the transverse oscillatory and the rotational mobilization for those with subacute or acute neck pain. Moving to the thoracic spine, looking at manipulation, we see that manipulation versus an inactive control, meaning really getting no treatment, that there was an improved pain in acute and subacute neck pain, but again at the short-term follow-up. Same, there was improved function in those with acute and chronic neck pain, again at short-term. Looking at mobilization versus manipulation, the pain relief was actually comparable at immediate term for those with chronic neck pain. Going to the lumbar spine, we see that there's a small to moderate effect found in favor of manipulation for patients with chronic low back pain that have a pain duration of greater than 3 months. And the effect increases over time at 3 and 6 months follow-up for reducing pain compared with exercise and PT as comparators. And there is moderate evidence to suggest that manipulation of the lumbar spine can also reduce disability. Looking at mobilization, the evidence isn't as strong to support the mobilization compared to the manipulation for those with chronic low back pain. However, versus active comparators, again, there's no statistically significant difference. So that brings the question, what do the experts think? And there was a panel looking at those who were deemed experts in the field about what case scenarios would be appropriate for cervical manipulation in those with chronic neck pain. And they created algorithms looking at both mobilization and also looking at manipulation for those with chronic neck pain. And here are their suggestions for who predicted that it was inappropriate to perform a manipulation or mobilization, and who thought it was an appropriate technique to do. And overall, looking at their algorithm and looking at their findings, what was their overall verdict? Their verdict was that even though the evidence on cervical manipulation that was shown to them had greater efficacy and with no more adverse events than mobilizations, those panelists rated that the mobilization was more appropriate and had a better benefit than manipulation, even though the evidence suggested otherwise. The experts had a different opinion. And why would you ask that? Was it their own clinical bias? Was it their comfort levels with certain people? What brought them to that conclusion or that decision to apply that in their clinical practice? They took that same group a year prior and asked them similar situations with those with chronic low back pain. Same thing, they created an algorithm for both mobilizations and an algorithm for both manipulations. And again, they came up with a summary of their findings looking at who thought it was inappropriate to perform a mobilization or a manipulation, and who thought it was appropriate to perform a mobilization or manipulation for a certain case. What was their verdict? Their verdict was that both were inappropriate in the presence of major neurologic findings. Major neurologic findings include that of lumbar myelopathy, progressive unilateral muscle weakness, and motor loss documented by repeat examination over time, sensory deficits other than related to dermatomes or peripheral nerves, and or electrodiagnostic findings of acute and or progressive radiculopathy. And they found also that more clinical scenarios were rated as equivocal in terms of, am I going to perform a manipulation or mobilization, either to the agreement that the benefits of the therapy are roughly equivalent to its risks. So now we're shifting our focus to the effects on the CNS neuroplasticity that spinal manipulation can offer. So when we look at neuroplasticity, what we're looking for people is a dynamic system. So we're looking at changes in neuron behavior that is a culmination of prior events and can leave with processes such as potentiation or upregulation or depression or downregulation at the synaptic level. Neuronal plasticity has its prolonged forms of long-term potentiation, LTP, and long-term depression, LTD. It's been identified in the spinal cord as well as throughout the CNS. And these processes are thought to participate in the experience of clinical pain. That neural plasticity provides the mechanism that can amplify transmission in nociceptive circuits, such as central sensitization, which can lead to central neuronal elements overreacting to a normal input with a persistent hyperexcitability. And that has been deemed long-term potentiation, which is the suggested amplification mechanism that is within the pain system. So how does spinal manipulation therapy come into effect with this neuroplasticity? It may provide an afferent input that impacts that spinal neuronal plasticity. The spinal manipulation therapy could activate small diameter A delta fibers in the skin and deep tissues, which can provide input to the spinal cord neurons, causing long-term depression to combat the long-term potentiation that has occurred. And it's suspected that similar changes will occur at the central and supraspinal synaptic targets in the brain, resulting in a central suppression, which can lead to a decreased back pain. And this theory was suggested by experiments performed on anesthetized cats. The long-term depression mechanism is a possible explanation for anti-nociceptive effects of various manual therapies, which also include spinal manipulation therapy. And the connection between spinal manipulation and spinal cord neuroplasticity is still highly speculative at this time. However, keep rubbing your cats. So what happens at the peripheral level? We know that musculoskeletal injuries can induce an inflammatory response, which influences healing, but also pain processing. And following manual therapy, there have been observed changes in blood levels of all these neurotransmitters of B-endorphin, endogenous cannabinoids, serotonin, anandamide, substance P. So then what happens at the spinal level? Well, there's a paper looking at rats and performing manual therapy on them, assessing what happened at the dorsal horn level within the spinal cord. And they showed that after manual therapy, there was decreased activation of the dorsal horn of the spinal cord, quantified by functional MRI in these rats compared to the control group. So we're seeing that there is an impact with performing manual therapy. And that thought comes off of the theory that joint-based manual therapy bombards the CNS with sensory input, and that has been associated with hypoalgesia, afferent discharge, reduction in motor neuron activity, changes in muscle activity, which are all indirectly implicate a spinal cord mediated effect from the manual therapy. So if you can, send all those presents and bombard the spinal level. Now looking at supraspinal effects, again, looking in the brain, we're seeing that there can be changes in activity during cold pressor tests after sham and spinal adjustment sessions compared to baseline activity. What does that mean? It means that it suggests that chiropractic or therapist spinal adjustments may alter sensorial processing of pain and unpleasantness. Pretty cool. So now we're going to look at pain and disability after spinal manipulation. What do you expect to occur after a high velocity, low amplitude thrust? With those who had a positive expectation that they would have a good outcome, they experienced a significant decrease in low back pain. If you had a negative expectation of spinal manipulation therapy, you had a significant increase in low back pain. And it's almost as if they knew it was going to happen. What's interesting too is looking at pressure pain threshold with spinal manipulation and lateral epicondylalgia. We see that it produced a greater change in pressure pain threshold with those who underwent cervical manipulation at C5, C6 compared to those who received thoracic manipulation. However, there was no difference in terms of pain-free gripping. And again, we can see that the cervical group who underwent manipulation had a significant change in their pressure pain thresholds compared to those of the thoracic. However, when we look at pressure pain threshold, we didn't see a change in those with neck pain after they had a thoracic spine thrust versus non-thrust. They did note that those with neck pain had improved neck pain after the thrust, however. Looking at pain and disability at the cervicogenic headache group, it's been suggested that a combination of cervical and thoracic or cervical independently can provide a small but superior short-term benefit for pain intensity, frequency, and disability, but not pain duration, compared to the control groups. However, just like Dunning mentioned earlier in 2012, the long-term impact is still not significant. Turning to the lumbar spine and pain and disability, with manipulation, we see that the thrust results in a greater reduction in pain for patients with chronic low back pain than the non-thrust. And then non-thrusts, however, still showed a larger reduction in pain compared to other active comparators. Looking at disability, there was a significantly larger effect in favor of thrust compared with active comparators. However, there is no statistically difference in disability compared to the mobilization group versus active comparators. Again, for acute low backs, it was associated with modest improvements in pain and function at up to 6 weeks with transient minor musculoskeletal harms. Now, looking at HVLA and radicular symptoms, because there is some speculation about the two and whether or not to perform it. So, looking at neck pain with radicular symptoms, in terms of evidence right now, we have very low quality evidence to help support spinal manipulation therapy and mobilization for cervical spine-related extremity symptoms. In fact, they even said we found only very low evidence compared with no treatments. Usual care and placebo, traction and exercise for that of spinal manipulation and mobilization. And as a result, the estimate of effect in the treatment of cervical spine-related extremity symptoms remains uncertain for that of manipulation and mobilization. And there's absolutely no evidence for thoracic spine-related extremity symptoms for spinal manipulation therapy or mobilizations. That leaves us wondering, what do we do? Turning our attention to the lumbar spine with radicular symptoms. For acute, we have moderate evidence that spinal manipulation therapy is more effective than sham therapy for acute lumbar spine related extremity symptoms. Think of your Flynn et al. OCS CPR guidelines. Looking at chronic, the research generally favors manipulation and mobilization for chronic lumbar spine related extremity symptoms, but again, it's of low quality. Now we turn our attention to what are the effects of HVLAT in regard to range of motion improvements. In regards to range of motion in the cervical spine and in the mouth, we see that there can be significant effects from spinal manipulation therapy seen in pre and post treatments. And for best results, we saw that on average there was a 3.5 millimeter increase for mouth opening for TMD patients and a 10-degree improvement for unilateral cervical rotation. For the thoracic spine, there were a few studies that identified specific range of motion changes immediately after thoracic HVLAT in the healthy subject group. The cedar supine to dysfunctional segments significantly increased bilateral lateral flexion when it was compared to a control group. And there was another that suggested there was no significant difference in forward flexion or lateral flexion when comparing it to the palpation group. And in an additional study, Manipulation to T9 resulted in a significantly increased thoracic forward flexion compared to sham procedures, but no significant changes in extension, flexion, or lumbar extension. Looking at lumbar range of motion, none of the 3 studies of the lumbar spine showed an effect on spinal manipulation on the lumbar range of motions. And SI joint manipulation reported no effect on the range of motion of the hip joint. Now we're going to turn our attention to the role of HVLAT and that of motor output. So looking at motor output, Havoc in 2011 had subjects that had self-reported history of subclinical neck pain. They found that they had significantly worse elbow joint position sense compared to people that had no neck complaints. And after a single session of cervical HVLAT at dysfunctional joints and segments, they found that there was a significant improvement in elbow joint position sense with those at subclinical neck pain. Looking at an additional study at Delgado in 2013, we found that the reaction time after a cervical HVLAT improved by 19% in individuals with subclinical neck pain. Healthy individuals also showed a 25% improvement post-HVLA. And it indicates that individuals with subclinical neck pain had decreased cerebellar inhibition compared to healthy individuals. And the thought was, if they're able to touch a keyboard faster after an HVLAT, they deem that the cerebellum has some sort of change after an HVLAT has been performed. Again, here are the reaction times for both the healthy and subclinical neck pain groups, both showing improvements in overall reaction time after the HVLAT was performed. And what does it say about the role of manipulation and strength? Does it help? Unfortunately, we cannot yet state that manipulation can significantly influence this parameter of strength, as the effects are still unknown, unfortunately. And that's a bummer. Looking at clinical application now. When do we perform this with our patients? Based off of the things we've discussed before, there are a few reasons why you can perform an HVLAT. Some can facilitate movement and improve range of motion, can relieve pain immediately. There is a psychological effect at the peripheral, spinal, and supraspinal level. It can meet a patient expectation, and it can help with time in terms of performing a manipulation in 20 to 30 seconds versus a mobilization for 3 sets of 30 seconds. Now looking here at our OCS testing clinical prediction rules, I found that the website listed below was a helpful tool for me when I was preparing for my OCS test. Looking at these studies listed below, you can go through them. There are some for cervical manipulation for neck pain. Here's one by Puentedura in 2012. And the big things we're looking at are just rote memorization for these. However, it's been criticized that this is a derivation study. And so that has certainly left room for people saying, is this appropriate and valid enough? Here's an additional one by Sang et al. In 2006, which is one I remember having on my OCS test. Again, NDI, bilateral involvement, not performing sedentary work greater than 5 hours a day. They're feeling better while moving their neck, did not feel worse with cervical extension, and they had a diagnosis of spondylosis without a radiculopathy. Here's another derivation study for cervicothoracic manipulation for that of shoulder pain by Mentgen in 2010. And here's a significant one for manipulation for low back pain by Flynn et al. In 2002, and you may remember it from the TBC classification system. And this one came up on my OCS test multiple times. When we look at those candidates who are a possibility for manipulation, typically they do best if they have symptoms less than 16 days, if they have one hip internal rotation of greater than 35 degrees, an identified lumbar hypomobile segment, their symptoms are not distal to the knee, and they have a FABQ work score of less than 19. And then another one by Cleland, which was touched earlier, for thoracic manipulation for neck pain of symptoms less than 30 days, no symptoms distal to the shoulder, looking up does not aggravate symptoms, FABQ PA work score of less than 12, if they had diminished upper thoracic spine kyphosis and cervical extension less than 30 degrees. And these are my references.